streaming.
Good afternoon, everyone. My name is Charmaine Green, and I'm from the Sidney Kimmel Comprehensive Cancer Center. And it's my honor to welcome you this afternoon to our Facebook Live session, which is part of our series on conversations about cancer, recovery, research, and reducing your risk. Our conversation today will be on HPV and head and neck cancer. And to begin our discussions, I would like to give our panelists an opportunity to introduce themselves. So if you could please introduce yourself and share a little information about you. We'll start with Dr. Curry.
Oh, it's okay. Ladies first. Let's have Dr. Leader and Laura go first.
Sure, I'll kick it off. And happy International HPV Awareness Day to all on March 4th, which is part of the reason we're doing this today. I'm Dr. Amy Leader. I'm a population scientist. I have a public health background to me. I'm a professor here in the Department of Medical Oncology in the Cancer Center. I'm also the Associate Director for Community Outreach.
No, I wasn't
Engagement.
on ISNT. We're doing a Facebook Live.
At our Cancer Center. Hey, Lauren, I think we hear you, if that's okay. Can you mute? There we go. And I've been studying, we'll talk about this later. I've been studying the HPV vaccine as a cancer prevention tool since it was first developed and put on the market, which is actually 20 years ago this spring. So also another milestone that we can always talk about. I'll pass it over to Laura.
Thanks, Amy. I'm Laura Rhodes. I am one of the clinical social workers in the Cancer Center, and part of my role here is supporting our head and neck cancer care team and patients. I also work with our lung cancer teams, our clinical cancer genetics group, and I support our senior adult oncology center. So, and I'm really happy to be a part of this panel today. So thanks for including me.
We're happy to have you.
All right. I'm Joseph Gray. I'm a head and neck surgeon. So I operate on patients with head and neck cancer and do reconstruction as well. And I am in the Cancer Center as a surgeon and clinician, but also involved in the clinical research arms of the university and the Cancer Center as well.
Well, welcome each of you. Thank you so much for accepting this invitation to participate in today's event. Now, to our audience, as we progress through our program, please feel free to put your questions in the Q&A section of Facebook, and our technician will give us the questions so that we can address them during the Q&A section of our program today. As was previously mentioned by Dr. Leader, today, March the 4th, has been designated as International HPV Awareness Day. And according to the International HPV Society, this day was established to spread awareness and education about HPV and to bring awareness that we now have tools to eliminate HPV and the ability to prevent cancers that are associated with HPV. So today we're going to talk about the cancer, head and neck cancer, and the correlation to with HPV and head and neck cancer. I'm going to begin with Dr. Curry. Could you please share with us some insights regarding cancer clinical trials, cancer disparities, and any relevant findings about HPV and cancer?
Sure.
Cancer.
So, you know, the human papillomavirus, or the HPV virus, is one of the most common viruses that cause cancer. Up to 10% of all cancer are caused by viruses. And in the past, the most common cancer that HPV caused was cervical cancer in the US. There's still small parts of the world where that's the case, but screening and prevention have actually eliminated it in a lot of places. In the US, we've seen a decline in cervical cancer, but an increase in head and neck cancers related to the same virus. The virus basically is the two same exact viral strains that cause most of the cervical cancer are the types that cause head and neck cancer. And we see it not in all head and neck cancers, mostly in what we call the oropharynx, which is the tonsils in the back of the throat, or the tonsil tissue on the back of the tongue, what we call the base of tongue. Traditionally, head and neck cancers were thought to be caused by smoking and alcohol. And then somewhere about 25 years ago or so, people started to notice that they were finding the virus in some of these tumors. And since that time, we've actually seen an increase in viral-related cancers to where In the past, tonsil cancers, maybe 20, 30% were caused by human papillomavirus. And now in our region, up to 90% or more are caused by the virus. So it's been an increase in almost 1% per year in viral-related cancers in the head and neck. And so it's something we call a cancer epidemic, in that it's become very widespread related to the virus specifically. So as smoking's gone down, the virus has actually increased in terms of prevalence among cancers in the throat and the head and neck.
Now, you mentioned smoking, but are there any other things that could contribute to HPV and head and neck cancer?
Oh, right. So the virus itself is transmitted person to person, right? So it's not necessarily related to smoking. When we think about cancers that are caused by smoking, it's actually, the cigarette smoke or the tobacco use that would cause a cancer. A lot of those we would see still in heavy smokers in the mouth, in the oral cavity, or in the jaw from people who use dip, or sometimes in the voice box from smokers. Now, oropharyngeal cancer, tonsil cancer, base of tongue cancer that is related to HPV, the only really known risk factor that we have is person-to-person transmission through oral sex. Now, we don't have a definitive mechanism to prove that, but we know that's most likely the way that it's transmitted, and it correlates with number of partners.
Now, what would be some of the signs or symptoms of head and neck cancer?
Well, that's one of the problems about it, is that it's kind of sneaky, right? So most people don't have a lot of throat pain. Most people that present are actually men who present with a lump in the neck that is painless. The first thing they'll show up with, which is actually a lymph node where the cancer has gone from the tonsil and spread to a lymph node in the neck, and that's what they'll present with. Some people present with pain in the throat. That does happen, but the most common scenario is a painless lump in the neck. So that's why we try to engage people in screening and raise awareness with events like this and encourage vaccination, because, what we hope to see in future data is that getting vaccines and prevention as a young adult or a child will prevent this kind of cancer in the future.
Is there a specific population that you see has a greater incidence of head and neck cancer associated with HPV?
Yeah, so I mean, the answer for head and neck cancer is kind of complex. In most cases, we do actually see white males are the most common individuals that get this viral-related cancer in the two most common viral types. But around the world, that's different, right? I mean, we see that in different populations, increasing incidence in a variety of populations, and also other strains of the virus, aside from HPV 16 and 18. And then there's also disparities in terms of who gets diagnosed and when. So even though we may see it more in white males, this cancer sometimes has a worse outcome and is more advanced if we see it in other populations. African Americans generally are known to have more aggressive cancers as a whole when they show up in the head and neck. And so that's a population that we like to pay specific attention to in terms of addressing it, trying to identify it early, and trying to eliminate it.
What are some other cancers that may be associated with HPV?
There are a number of other cancers. As I mentioned, cervical cancer, anal cancers, penile cancers, a lot of other cancers can be related to HPV. And, there are some other potential relationships. We see it sometimes in skin cancers as well.
What does the research show regarding the effectiveness of the HPV vaccination, and how has it impacted cancer rates associated with HPV?
Well, as Dr. Leader mentioned, the vaccine has been around for about 20 years, right? So it takes a long time from infection to developing cancer. So most of the people that we see with throat cancers related to HPV at this point probably had an infection 15 or 20 years ago. So before the vaccine was even available. Now, if you take into account that the uptake of the vaccine has increased, the indications for giving the vaccine have increased, that means more and more people over time have gotten vaccinated. Now, there is some early data that we've actually looked into on the population level to suggest that the vaccine is actually lowering cancers already. We really suspect that it is, and it will in the future, but we've yet to see the effect in the data because of the long time lag that occurs between infection and cancer. So unlike other viruses, like if you think about, sometimes people think about chickenpox and shingles and the herpes virus, right? That virus lives in a nerve, so it's hidden somewhere in the body, and then you get, manifestation of it by shingles or something like that. This virus is actually localized to the area where it gets infected. It doesn't spread throughout your body. It's not hiding in a nerve. It's literally just in that tissue in the throat. So it's somewhere in there hiding for a long time before it actually becomes cancer. We think it causes a chronic inflammation that eventually your body can't tolerate anymore, and that's what causes the cancer. So we think that people, children, kids, and even adults who can get vaccinated, if they haven't been exposed to the virus, will be able to avoid this kind of cancer. Once you're already exposed to the virus, it's not really clear that it can prevent you from getting the cancer. That's why we like to vaccinate people younger or earlier before they're exposed.
Can they still be vaccinated if they do not know if they've been exposed?
I mean, yeah, you're allowed to be vaccinated up to about 45 years old.
Okay, now what would be some of the treatment options for individuals with head and neck cancer associated with HPV?
Well, it's always a difficult thing to talk to a patient about the HPV virus because, there's sort of existing social stigmas about like, how did I get this? How do we transmit it? All that kind of stuff. But I usually tell people it's actually, it's not great news to get diagnosed with cancer. Obviously, it's a hard diagnosis, but the good news is that those tumors are much more sensitive to treatment and have much higher cure rates than our smoking and alcohol related cancers. So the good news is we have a lot of treatments. Sometimes that means removal or sometimes that means radiation. Those are your two mainstays of therapy, but we often will combine them or add chemotherapy. And nowadays, we've actually had increasing approvals for immune therapy for head and neck cancers related to the virus or otherwise. And the immunotherapy seems to be very effective. And so it is a very exciting development over the past decade, which continues to expand. As recently as this year, we got new indications to use immune therapy earlier and earlier in cancer treatment so that we can hopefully attack the cancer with our own immune system before your immune system has been hit with other therapies like removing of lymph nodes from surgery or chemotherapy or radiation.
Can you explain immunotherapy?
Yeah. So it's one of those things that you see and hear a lot about. Like the most commonly commercialized drugs that you'll see are things like Keytruda or Opdivo or Libtayo, which are the three main drugs that we commonly use for these kinds of cancers. They're not all indicated for head and neck cancer, but they all are all indicated commonly for a lot of cancers. What they actually do is increase the immune responsiveness to discover and destroy the cancer. Cancer has a way of expressing some markers on its surface that it's kind of like it shuts the light out in a room. So it can grow without your immune system seeing it. And what the drug does is flick the light back on so your body can now see it, attack the cancer, and either start to fight it or sometimes eliminate it. So it's given some really exciting results in terms of producing decreased size tumors, maintaining some tumors, and even eliminating some tumors.
You mentioned that the therapy identifies markers. What are markers?
Oh, so the key marker that we use is something called PDL1. That stands for Program Death Ligand 1. So there's a mechanism that cells have to say, hey, there's nothing going on here. We don't need an immune response here. Well, the cancer co-opts that system. It steals that system and says, hey, look, this is nothing. We're fine. We're not anything bad. And what it does is it tells your T cells not to attack. So it turns your immunity off in that area. It causes them to be, you can think of them as sleepy or what we call senescent or inactive or what we call exhausted. And it tricks the immune system out of responding, whereas the therapy will actually trigger them to respond again in some patients.
Thank you, thank you, thank you. I'm going to move now to Dr. Leader. Thank you for joining us. My first question to you, can you explain to us what is population science?
Sure. So I get that question a lot. Seems like an easy term, but not everybody really understands it. So Dr. Curry, he sees his patients one by one by one, 10 o'clock appointment, a 10:15 appointment, a 10:30, an 11 o'clock appointment, and he takes care of them one by one by one. And Laura does too, taking care of our cancer patients, sometimes one by one by one. A population scientist or a public health person like me, I think about an entire community of people as my patient. If an entire community of people are doing well and are healthy, then I feel like we're doing a good job. But when I think about it, I think about, well, where do they live? And what are the resources in their neighborhood? And what are they having for dinner? And what is the stress level in their community like? And what are the opportunities for the children? And where are the clinics? And how can they get there? And is the environment conducive for good health? And so I wouldn't say they're my patient, I'm not a clinician, but I think about it on the whole level, on a community level. So when I'm doing research and I'm working with I'm always working with groups of people and thinking about it from a population health or a population science level rather than an individual patient.
How does your work as a population scientist inform cancer research?
Yeah, well, everyone lives in a community. Everyone goes home at the end of the day. Everyone eats dinner. Everyone watches things on TV and searches things on Google and, does things on Saturday afternoon that are a good idea or a bad idea. And, it used to be wearing seatbelts and smoking cigars and all those things. But, we spend very little time, unfortunately, with people like Dr. Curry and Laura Rhodes. And we spend most of our time on our own in our communities with our families. And so, when we send our cancer patients home, where are we sending them? Where are they going home? Are they eating healthy? What's the food like in the fridge? Can they get to the medicines that Dr. Curry is prescribing them? Do they understand what they're supposed to do and how often they're supposed to take those medications? Do they know the phone number to call to Laura if they're having problems? And so most people spend almost all of their time in community and in society. And so thinking about how we can improve that environment ultimately improves the outcomes for cancer patients.
Now, there's a term that is used often, it's the social determinants of health.
Mm-hmm.
Can you explain what they are and how they impact your work and the work of the Cancer Center in treating their patients?
Yeah, so I think a lot of what I just described, those things in community where people live, work, play, pray, and spend their time are the social determinants of health. And so we think about someone's physical environment and where they live, and are there parks for them to take a walk on a Saturday, and their economic environment, and do they have enough money to afford their food and their rent or their housing? All of the social fabric of their life, and do they feel connected? There's a lot of research about social support and social connectedness as a pathway to good health. We know that as people get older, they become a little more isolated and a little more lonely, and we know our cancer patients tend to be older. So thinking about pathways to social support are really important. And so all of these things, all of these drivers that are outside of our health system are having a major impact on a cancer patient's outcome. And I think the Cancer Center and other cancer centers, we do care about them because they have dramatic implications on how well our patients do, and the families that support them.
Thank you. Now, can you share with us the type of research that you may be involved with that is related to head and neck cancer and HPV?
Yeah, sure. So as I mentioned, the vaccine is approaching its 20th anniversary this spring, which is awesome and a major accomplishment in the cancer prevention space. It's my favorite vaccine because we also have the hepatitis B vaccine when we think about preventing cancer, but the HPV vaccine is my favorite one. And I don't always think about it specifically to head and neck cancer. I sort of think of it more broadly, as Dr. Curry was saying. It really can fight all these, many, up to 9 different cancers now. And again, my research focuses on the population side of that. So how can we increase rates of HPV vaccination in our communities? So right now, the data shows that about 57% of people who are eligible for the vaccine are up to date, which leaves massive areas of improvement. And so the main group of people, as Dr. Curry was alluding to, we try and get this in our teens and our adolescents all the way down to age 9. And so sometimes the research involves helping teenagers or young adults make some of their very first health decisions on their own about getting a vaccine. And how can we support young adults making decisions around getting vaccines? And a lot of it is supporting parents on making decisions about vaccines for their children. And we think about that in 2 ways, really, and what's the message they're receiving, and who's the messenger who's delivering it. And in terms of the message, we can think about tailoring those messages to match different communities and their lived experiences. And so a message that might resonate with me might be different than a message that resonates with Laura or with you. And so thinking about how do we tailor those messages and reasons for vaccination can actually start to increase vaccination rate in our communities. And then the other side of that is the messenger who delivers that message. And typically it's people like Dr. Curry. When you ask a group of people, who do they trust most for their health information? It's their doctor. But getting back to that point, we don't spend a lot of time with our doctors. And so we're constantly seeing things on the internet and on social media and all of these places that are influencing our decisions. They've become the messenger when we can't get to Dr. Curry. And so how can I partner with people that are trusted messengers in our everyday life? That could be church pastors. That could even be other moms, other mom influencers, grandparents, and Black captains and people like that, other trusted messengers, where people can hear about the vaccine in a safe space and make a good decision.
Now, you mentioned that the vaccine is coming on 20 years.
Yeah.
And understanding that it is a relationship between the patient and the physician who would administer the vaccine. Has there been a specific drive? Now, starting at age 9, we're talking about pediatricians.
Yeah.
So has there been a specific drive to address pediatricians to let them know the awareness, the importance of this vaccination in children as young as 9?
Yeah, pediatricians have had a huge emphasis on the HPV vaccine and have played a huge role in the last 20 years of getting our children vaccinated. And there have been a lot of the frontline vaccinators have been in pediatric practices. Dr. Curry mentioned that you can get this vaccine as a young adult and actually even up to age 45 if you so desire. And so it does sort of enter into the primary care or adult medicine space, but by and large, a lot of the efforts in the early days and to this day lie in the pediatric practices and with those pediatric doctors.
And do you see that they're still continuing to stress the importance of this vaccination in that particular population, the children's ages?
Yes, absolutely. Now, the discussions have gotten noisy. It was probably a nice way to say that in the recent year or so about the vaccine landscape is changing. And so they used to be a much more straightforward discussion about the vaccine, and now it's become a little more complicated. So now our doctors are spending more time explaining why the vaccine remains important, even in some current environments and current situations. But they absolutely remain sort of our frontline vaccinators. And I believe will continue to do that for us.
Good to know. Is there any other research that you've been involved with to promote HPV vaccination, not related to head and neck cancer?
Yeah, some of it has been around cervical cancer and some of the work in anal cancer. We've done some studies and work together with the LGBTQ plus population and community because they're at increased risk. Little international work, but mostly here in the Philadelphia area in terms of reducing risk and getting people vaccinated in different communities. Yeah.
Where can people get more resources and more information about the HPV vaccination and where they can get it if they have not already done so?
Yeah, the American Cancer Society, which is one of our very trusted community partners or partner organizations in this fight against cancer, runs something called the HPV Roundtable. And so I don't always like to recommend Googling, but if you Google the American Cancer Society or cancer.org, HPV is right there on the front page. And there are so many resources on the American Cancer Society website for young adults themselves, for parents, for grandparents, for doctors, for nurses, for any clinicians who may be listening today. American Cancer Society is a really trusted resource for HPV information.
Thank you. Now, as a population scientist, can you explain to us how your work involves or engages the community?
Yeah, like I said, they are some of the most trusted partners. And we're realizing more and more and more that trusted partners are really strong messengers for delivering information to parents and young adults and others. And so I've also done some work with peers where we've trained young adults to be educators about the vaccine and to educate their peers. Because sometimes a young adult, a teenager, doesn't want to listen to their parent. They don't want to listen to their doctor. They'll listen to their friends.
Mhm.
And so we've done some peer-to-peer support education with teens and young adults to become the educators in getting vaccines. Just one example.
Thank you. Now we have a question. Now, either you or Dr. Curry can address this. Are there screenings that are available for head and neck
Oh, that's
cancers?
a Dr. Curry question. I'll pass it back.
All right, fair enough. Yeah, so there are screening events. For example, SKCC holds screening events throughout the year, and frequently we will be a part of that. We've done a number. We frequently do them at the Torresdale campus in Center City, and they're happening in our New Jersey sites as well. So there are quite a few cancer screening events that we hold throughout the year. Sometimes we do them on site. We did one at Dietz and Watson recently on site, for example. And there's also the mobile screening van, which will travel around to different sites and communities and conduct screening events.
Now, what would screening look like for that?
Well, we found that the most useful and effective screening events are when we combine with other cancers, right? So we'll do a discrete screen for head and neck cancer, which is usually an examination of the head and neck. So if we ask people, what we do is we'll feel the neck, look for any lumps or bumps. We'll look in the throat, look in the ears, et cetera. But when it comes down to the cancer we're talking about today, it's, looking in the throat and feeling the neck. Those are the two main things. Any abnormal new growths in an adult over 40 is something we're kind of concerned about and looking for. And in fact, a lot of people's dentists do a very thorough exam and will look and pick up some of these things as well.
I was getting ready to ask you that. It would be the same thing that your dentist would look at when he does your
Yep.
oral examination.
Yep.
Thank you for sharing that. Now, our third guest is Miss Laura Rhodes. Welcome, Laura. Thank you for joining us. Can you give us a brief overview of what you do as a social worker in the cancer center?
Sure. So I usually explain my role as an oncology social worker as being in two main buckets. So the first bucket is emotional support. So helping patients cope with a new diagnosis and cancer treatment, helping people figure out how to communicate with their family and friends about their diagnosis, help them in conversations with perhaps their young children, supporting care partners through this process, and then connecting patients with other survivors through either one-on-one peer support or support groups. So that's one bucket. And then the other bucket is helping connect people with important concrete resources. Things like help with navigating, applying for disability benefits, or help with transportation to appointments, financial help, home health care, and of those more tangible things that can help make this process a little bit easier.
And you mentioned a oncology social worker. So as an oncology social worker, would your focus be different than a social worker in another field or another type of medicine?
So, I work specifically with patients with cancer. So, as a whole, I think social workers' role is to oftentimes make a difficult situation a little bit easier for people. So I think that's kind of universal. The resources around cancer and cancer treatment are, though, very specific to what I do as an oncology social worker.
What are some of the services and resources that are available, and even programs specifically for patients with head and neck cancer?
So care for patients with head and neck cancer at Jefferson is very much a team approach. So oftentimes patients will have several different physicians. So, in addition to a surgeon like Dr. Curry, they'll be working with maybe a medical oncologist, a radiation oncologist, oftentimes a supportive medicine physician, also known as palliative care physicians. So these are doctors who treat the symptoms and the side effects that come along with cancer and cancer treatment. Also, many of our head and neck cancer patients are working really closely with a speech therapist, a nutritionist, sometimes a physical therapist, nurses, nurse practitioners, and social workers. And then in terms of programs, so the Cancer Center offers a number of different support and education programs we have a Cancer Support and Welcome Center that's right here in the Honickman Center on the 15th floor. So there are programs like yoga and Reiki and massage therapy. There's kind of more traditional support groups. So we have a group for caregivers, and we have a group that's specifically for patients with laryngeal cancer. And then we recently partnered with a national organization called Immerman's Angels. So this is a nationwide organization that can match people who are more newly diagnosed with cancer with folks who are kind of further along on their journey for one-on-one peer support. And they have this huge network of people that they call their mentor angels. So they're able to match people really closely, by diagnosis and cancer treatment, age, kind of life situation. And I think sometimes just connecting with others who have been through what you're going through can be really helpful in helping people to feel understood and heard, and sometimes less isolated. And then sometimes it can help to talk to a professional. So I'm clinically licensed. The other social workers on our team are clinically licensed. So we do one-on-one supportive therapy with patients for, help with just kind of coping with something that is new and challenging in their life. Sometimes helping people learn new strategies for coping or for relaxation. So there's lots of different things. It's not a one size fits all type thing. Different things are helpful for different people at different points in their journey.
So would would it be sort of targeted or specialized for the particular patient? So it's not like a one size fit all, would that be correct?
Exactly. Yes.
And how can someone or a patient take advantage of these services that you've just mentioned?
So they should ask their care team, ask their doctor or ask their nurse, is there a social worker that I can connect with? So as I mentioned, I work with the head and neck cancer team and the lung cancer teams. But for people who, might be coping with other types of cancer, we have social workers who are working with each of the care teams at Jefferson. There's also, too, I just wanted to add, there's a great national organization called the Head and Neck Cancer Alliance that does all different types of education and support programs that are specific to head and neck cancer.
Oh, that's good to know. Now, would there be the opportunity for someone that is not a Jefferson patient to take advantage of the services and the resources that you in your area will provide?
So our Cancer Support and Welcome Center, almost all of our programs are open to anyone in the community. So whether people are getting treated at Jefferson or at another hospital in the area, the programs are open. Some are in person. A lot of them we do with a hybrid model. So some people will be in person and some people will be participating by Zoom. For our laryngeal support group, for example, we have people who are joining us from literally all over the country. We have some folks who come in person and then some folks who are joining us by Zoom.
Is there a telephone number or an email address that they could connect to, or the website that they would connect to find out those services and programs?
Yeah, so the phone number for our Cancer Support and Welcome Center is, I can put it in the chat if it's 215-955-1800, but I'll put it in the chat.
That was 215-955-1800. Is that
You
correct?
got it. Yep.
All right. For those who are live, they will not see your chat.
Oh, okay. I'll stop typing then.
Thank you so much. Now, is there any other information that you feel would be important for individuals and families that are being treated with head and neck cancer? Is there anything that you as a social worker feels that would be good for them to know, maybe at the beginning of their journey? Somebody might be newly diagnosed and you are speaking to them for the first time. What would you say to sort of help ease their journey moving forward?
So I stress to people that this is very individual. So there's not a right or a wrong way to feel. What you're feeling is what you're feeling. And sometimes, and Dr. Curry mentioned this a little bit, there can be like a shame or stigma around head and neck cancer specifically because of its association with HPV infection or its connection to alcohol or tobacco use. Or sometimes people will have speech changes or appearance changes after surgery. And sometimes that can even make people reluctant to seek medical care. So I always stress to people, you deserve good care. You deserve to have team members that you feel comfortable with, that you trust, team members that you feel like listen to you. And it's also really important that people tell us when they're struggling. You know, if you are having a symptom or side effect, whether it's physical or emotional or financial, we want to know. Emotional side effects, things like anger and worry or sadness, are just as important as things like pain or difficulty swallowing. We just don't want people to suffer in silence. And oftentimes there are things that we can do to help.
And would you be able to refer them to other physicians or other services if you feel in your conversation that they need additional support?
Absolutely. Yes. Yeah, and I guess, Charmaine, the one thing that I didn't mention is there are also a lot of financial help and resources. We know cancer is expensive. You know, even if you have the very best insurance, cancer is expensive. A lot of times people have a reduction in wages because they're taking time off from work. You know, at the same time, they're paying more because they have to park or they're traveling here or they have insurance copays. So if you're struggling financially, say something, because a lot of times there are some ways that we can help.
And you can help them navigate some of those financial barriers?
Absolutely.
That's good to know.
Yeah, I would say that, just to jump in, is that, you know, it's for most people, a diagnosis of head and neck cancer is the hardest thing to go through in their lives. And so from my perspective, people like Laura on the team are some of the most critical elements of the team because they know the system, they've been through it with other patients, and they can be there and kind of help navigate and direct patients to other members of the team. All right. So we may have all of those other elements we discussed: speech and language pathology, patient navigation, financial assistance, all those things. And having somebody you can go to when you have a problem means that you don't have to have all the answers. You don't have to remember all this stuff. You have a person you can connect to that really helps you get in to see the right person at the right time.
Thank you. Thank you. Now, I don't see any other questions available. So I'm going to ask if there's any one key takeaway that each of you would like the audience to leave this event with.
Well, I'll jump in quick. I would just say that, you know, the thing I always tell people is, like I said, you know, this is often the most difficult thing that someone will deal with in their life, but we can help, we can treat it, and in many cases we can cure it. So there is hope there, and you can rely on your team to get you plugged in with the right people and the right elements that will help you move forward.
From the other end of the spectrum, on the prevention side, so we can keep people from Laura and Dr. Curry. If you know someone who's eligible for the vaccine, the HPV vaccine, please get it. Please encourage them to get it. It is one of the most effective ways we know how to prevent cancer. And all of the things we just talked about today could become a moot point if we were to get people vaccinated. Not that we don't appreciate Dr. Curry and Laura Rhodes, but really, we could prevent a lot of cancer.
And I think I would just add that you don't have to do this alone. There are people on our team to help you through this journey.
Well, thank you all. This has been a very informative conversation, at least for myself, and I hope that our audience has also found it informative. We thank you for joining us today. And if you are interested in seeing this event again, you can go to our Facebook page. It is being recorded and it will be posted on the Cancer Center, the Sidney Kimmel Comprehensive Cancer Center Facebook page. If you have any other questions, please email our outreach team at skccoutreach@jefferson.edu. Again, Thank you for spending your time with us this afternoon, and I hope you enjoy the rest of your day. Thank you.
Thank you, Charmaine.
Sure, thank you.